uh, from genetics will down to earth back into hypoglycemia. I'm sure you heard of recently a lot of talks on hypoglycemia, which has come into discussions and also a big clinical problem. But some of the recent papers have brought out some new data, and when you read the paper, sometimes you do not really tease out exactly what they're talking about. So I thought I'll just share with you and then make it clear exactly what we talk about. But I heard about the DEVOTE trial and what they did. My friend John Buse and Bernie Simon has done some analysis on the hypoglycemia in these studies, and I'll just share with you. Okay, it's going to. So first is the impact of hypoglycemia. We were involved in a study called HAT study, which is actually funded by Novo Nordisk. This was actually one of the largest studies, which involved almost 27,000 patients from different parts of the world, and looking at the real world experience of a subjective analysis of hypoglycemia by patients. And then what they had almost 8,000 patients with type 1 diabetes, 20,000 patients with type 2 diabetes. It's a pretty large number of people, and they had two parts of it: a retrospective analysis from history and also a prospective data collection from what is happening to them. So that was a very powerful study. And what is found was that amazingly the number or the percentage of patients with hypoglycemia was pretty high. I'm giving you only the prospective data 4 weeks after the baseline data was. What you can see, any hypoglycemia was almost 89% in type 1 diabetes, 43% in type 2 diabetes, and you have non-severe and nocturnal. Nocturnal, which occurs in the night. Of course, non-severe is you don't want a second person to help you. That is, the hypoglycemia is divided into three: nocturnal, severe, and non-severe hypoglycemia. And you can see severe hypoglycemia is also pretty high. Now, this is very high compared to what is written in the textbooks. So this is what is called epidemiology of hypoglycemia. And we do not realize that patients do actually experience such high percentage of hypoglycemia. What is shown here is the estimated incidence rates of hypoglycemia, which is also pretty high. Any hypoglycemia, 17%, that is 17 times in a year, or 15.8 non-severe. And what you can see is that hospitalization was necessary almost 0.3%, which is very, very severe form of a problem, clinical problem. So what I'm trying to say is that what we usually quote is the hypoglycemia rates from the studies like the advanced UKPDS Origin Accord. Those incidence rates are very low compared to what you see in the real world, because in randomized controlled trials, people are monitored and their hypoglycemia is prevented because they do blood glucose much frequently. But in the real world, it's much, much different. It's almost 10 times more. And therefore, it is a clinical problem in treating diabetes, which is underestimated, and that's the first point. So what we learned was that cost of hypoglycemia. Now we're talking about this from a clinical point of view, but from the patient's point of view, there are direct costs and indirect costs. Any severe hypoglycemia requiring hospitalization is going to cost not only from social point of view, emotional point of view, but also from financial point of view. Now, there's not been very good studies on hypoglycemic cost in the world, but we're trying to look at this, and the HAT study has got some data. What is the next thing? So what we learn now is hypoglycemia is more frequent. It's a major obstacle for optimal diabetes control, and hypoglycemia has major socioeconomic consequences. The next question is, what is the variability? There's something called variability. Of course, you all have read this in the textbooks about what is called glycemic variability. But the glycemic variability has got a lot of other clinical implications. It is not just going up and down, but it has got other predicted. One is it can actually predict hypoglycemia. I'm going to say this is what is called glycemic variability. You all know this. You have up and downs. The same HbA1c two people have, but one person has very low blood glucose and very high blood glucose. But when you do a test in your clinic, we are very happy he has got an HbA1c which is similar to somebody who has got a much smoother control. So glycemic variability exists very different from the HbA1c that you test. DEVOTE trial. I'm sure all of you know what is DEVOTE trial, but if you do not know what is DEVOTE trial, this is the only trial done for a cardiovascular outcome comparing two basal insulins, which is degludec and glargine. And what was found was that it confirmed the cardiovascular safety of the new insulin, which is degludec, which is non-inferior. So either you use glargine or degludec, there is no difference in the cardiovascular safety. Both are quite good. But the point which is driven was that a 40% lower rates of hypoglycemia was seen with degludec and almost 53% decrease in nocturnal hypoglycemia. Now, why are we projecting this here is that not to just show what is superior or which is inferior. The point was, has this hypoglycemia has an effect on cardiovascular outcome, on mortality, which has been shown earlier in some studies. Now, DEVOTE 2 was done by Bernie Zinman and John Buse. What they looked at was that whether we can look at fasting plasma glucose in these patients and predict hypoglycemia. Very simple thing. That is, they took from each patient the variance of 3 log transformed pre-breakfast blood glucose, and that could actually predict hypoglycemia, severe. If they have very low glycemic variability, then there is low risk of hypoglycemia. The next point was glycemic variability was significantly associated with overall hypoglycemia, nocturnal hypoglycemia, and severe hypoglycemia, which is a new clinical marker. That is, by looking at the fasting plasma glucose levels, you are predicting hypoglycemia in a patient. The next point was about outcome, the same studies. Now, you have read the results of ACCORD Advanced Examiner, and people have been projecting to you all that cardiovascular outcome about the LEADER trial and the ORIGIN trial, etc. Some of them are non-inferior, some of them showed superiority. But one of the clinical knowledge or clinical information or medical science which has actually evolved out of all these trials is about the connection between hypoglycemia and death. And that's important. Hypoglycemia and death, which is not known earlier. ACCORD trial, one of the first to say that mortality rate was associated with hypoglycemia both in the intervention group as well as in the standard group. Of course, it is more in the standard group. The other point was, they also showed that the advanced trial is another trial. One is the ACCORD trial, the advanced trial, where actually we used not much of insulin, they used glycoside, and they said that even just like the ACCORD trial, so it was reproducible in 2 trials in the first place. Then came the other one called the ORIGIN trial. ORIGIN was a special trial where basal insulin glargine was used to see whether you can reduce cardiovascular outcome by using insulin very early in type 2 diabetes or impaired glucose tolerance. But the point about this study was that actually the frequency of hypoglycemia was much less, even though insulin was used to actually target an blood glucose of 95 fasting. But what came out of this was one important mechanistic answer, connection between hypoglycemia and death, and that was arrhythmia, because you can see 1.77% was the hazard ratio for cardiovascular, and death and hypoglycemia. So one of the mechanisms of hypoglycemia causing death could be arrhythmia, which may go unnoticed, unobjugated, and cannot be even sometimes recorded in a hospital setting sometimes. So severe hypoglycemia hazard for all 4 outcomes was higher. The next one is again going back to the DEVOTE 2 trial. It was very interesting that severe hypoglycemia was predicted by variability, but it also, the glycemic variability just measured by the fasting plasma glucose also predicted all-cause mortality, which is very strange. And then they wanted to look at, and what is it they want to look at? If hypoglycemia is related to cardiovascular event or death, there should be a connection between the time it occurred and the event which happened. And that is what you find here. That is, they looked at any time hypoglycemia and the cardiovascular death, within 365 days, within 60 days, within 15 days, the connection was still present. That means after an event of hypoglycemia, severe hypoglycemia, that the death was actually almost predictable. And that was a very important finding from the DEVOTE 3. So this is called the DEVOTE 3 analysis. However, there was a catch here. Now, should not walk out of this room having an impression that hypoglycemia actually causes cardiovascular death. Actually, when they did all the statistical analysis, they found correction for HbA1c. Hypoglycemia was associated with death rather than just cardiovascular events alone. So all-cause mortality was, so it could be even a death which is not recorded as a cardiovascular death. It may be even arrhythmic death. So whatever it is, all-cause mortality was connected with hypoglycemia. The other point is, although there are so much of hypotheses created to connect mechanistically how hypoglycemia can cause death or cardiovascular event, none of these analyses have made it really sure that hypoglycemia can actually precipitate or cause death. There is a connection between hypoglycemia and those patients who experience frequent hypoglycemia have an increased risk of death. Those people who get very severe hypoglycemia, it can be followed by death, but the connection is still not established for one simple reason, and that is most of the people who had hypoglycemia also had, I'm going to come to that slide now, 1 minute. Most of these people also had other comorbidities. So they were already vulnerable patients. It may be possible that hypoglycemia is incidental and the patients who are going to die are already having a high risk of hypoglycemia. So it's very complicated. So from clinical point of view, it is better that you do not precipitate hypoglycemia in patients who are vulnerable, who are fragile, who are old age, who have comorbidity. So I'm going to go back to that slide. So mechanistically speaking, there are so many things. If you want to write an essay on hypoglycemia, you can talk about all these things which have been recorded, like endothelial dysfunction. Every time you have a hypoglycemia, you can have an inflammation, coagulatory risk factors, and sympathetic overdrive. All this can be actually implicated as mechanistically connected between hypoglycemia and all-cause mortality or cardiovascular events. The other one is acute indolent. So I think the take-home message should be that hypoglycemia has major pathophysiological, psychological, and socioeconomic impact, and is often underreported or underestimated. Please ask for hypoglycemia because that has to be corrected. Glycemic variability, which is a new term which has come from the DEVOTE trial, has now produced a new science that it can predict hypoglycemia as well as even predict death. And of course, it is associated with hypoglycemia. Options to decrease the risk of hypoglycemia should be considered when choosing therapeutic strategy. Now, what has this made in our clinical? That is why now you have different targets of HbA1c in different people. You do not treat everybody to bring down their HbA1c to below 7. An 85-year-old man sitting in front of you has to live probably another 15 years. So you don't want to produce you don't want to target an HbA1c of 6.5 with the risk of hypoglycemia because you may invite his death early. And that is why now all the regulatory bodies, ACE, ACE, ADA, everybody now said you should go for personalized, individualized hypoglycemia. A 35-year-old man who has to live for another 65 years has got a good heart, good kidney, good beta cells. You can aim for an HbA1c or target an HbA1c of 6.5. Very different from somebody who is 85-year-old. So just like Mohan was talking about, you have to personalize your target of HbA1c, and that is a take-home message. Thank you.